Today we have Jefferson Baer, who is down at Midtown. He's head of the Echo unit down at Midtown, and also head of the medical clinic there. Jefferson started out at UNC, where he got his BS and also an MD degree. Then went from there to, I'm blanking on where, he went from there to Pennsylvania as his, started his residency, and from Pennsylvania then went to do his fellowship at the University of Washington in Seattle. So he's moved around a lot, but they all seem to be legitimate reasons for him to move. But we're looking forward. I think this is a talk, particularly for the residents, it comes at the right time in your career, because for years, aspirin has been the bedrock of our treatment of heart disease. And now some people have raised the question, well, is it really what we're making it, or is it something somewhat less than that? So I look forward to hear Jeffrey address the issue of what do we do with aspirin these days.
All right, thanks a lot, Doug. So I've given this talk in various forms over the last couple of years as more and more research has come in, and hopefully you guys will find it interesting. So I have no disclosures. First, what am I not going to talk about? I'm not going to go through every single aspirin trial because it's really boring to sit and talk about 14 trials and go through every nitty-gritty detail. I'm kind of more of a big picture guy, and I like to give you guys some real useful information that you can take back to the clinic. The next thing I'm not going to talk about is aspirin and secondary prevention. We know that works. There's not really a debate about it. We can debate about, do you need to use it with Eliquis or triple therapy, dual antiplatelet therapy, but in general, we know it works. There's really not a lot of controversy. And then the next thing that's brought up is aspirin and the prevention of gastric cancer. There's some calculators out there that will include the reduction in risk from gastric cancer, and should we include that when we have discussions? And unfortunately, I'm not an oncologist, so I don't really have a lot of information about that. But that is something that some people report you should think about when you decide about whether you should use aspirin in primary prevention. So which medication has a higher overall risk of serious side effects, aspirin or statin? And I think if I asked this question 5 years ago, I would have gotten a different answer. I think the message has gotten out that really aspirin has some pretty serious potential risks associated with it, while statin is really quite safe. And what's funny in clinic when you see people is they come in there and they don't want to take their statin. They're worried about all the dangerous side effects of statins, but they're sitting there taking their 325 of aspirin and think it's just not a problem at all. And I think we're really trying to get the word out that statins are a lot safer than aspirin. And in fact, if aspirin went before the FDA today, it almost certainly would not be approved. Its bleeding risk is probably similar to Eliquis, to be honest. In one of our clinical trials, it had equivalent bleeding risk to Eliquis, and we know that's not a over-the-counter medication. So when you look at risk of statins causing liver failure, really no different than placebo. Statins do cause rhabdo, but really aspirin hemorrhagic events is 55 per 10,000 patient years, so it's a lot more than statin. But this is where we kind of started off many years ago, aspirin a day, the wonder drug that could save your life. And so how did we get here? At some point we were talking about, well, maybe we should just put aspirin in the water. That was the good thing to do. And I think we've realized that would be a really pretty unwise direction. But now we have these things coming out, breaking news, a surprising FDA reversal on aspirin. The FDA has concluded that the data do not support the use of aspirin in primary prevention of cardiovascular disease. In such patients, the benefits have not been established, but risks such as dangerous bleeding are still present. So how did we get here? I mean, it's very confusing, and you have patients coming in all the time. Sometimes they're stopping their aspirin, sometimes they're starting their aspirin, and it's confusing to us. So we'd like to be able to give them some guidance. So this all started many years ago, 1989, with a physician's health study. And basically it was 20,000 men randomized to aspirin. Interestingly enough, it was every other day for about 5 years. Now, it's really important to realize this is pre-statins. And they found really a massive reduction in the risk of heart attacks if they took an aspirin every other day. And so this started the whole kind of trend of the wonder drug, heart health, stroke prevention, saving lives, pain relief. And so people really started on this aspirin bandwagon. And then in the last year, we've had 3 trials come out that have kind of been thrown a damper over this enthusiasm. There are a lot of trials in between that kind of, for the most part, supported the physician's health study. But these last 3 trials really made us question whether we should be using aspirin. And they were the ARRIVE trial, which was basically done in supposedly moderate risk patients, the ASCEND trial done in diabetics, and the Aspirin trial done in patients greater than 70. And this led to this whole new idea, well, maybe we shouldn't be taking aspirin, and really there's a lot of dangers associated with it. So what has changed since the Physicians' Health Study is we've all changed. People are eating better. They're eating more fish. They're eating more fruits and vegetables. The message about Mediterranean diet has gotten out. People are into more yoga, meditation, exercise. Smoking rates have gone down. And a big thing is that statins are now out. So the landscape has completely changed. I don't think aspirin changed, but I think we have changed and our population has changed, which may have tilted the risk-benefit ratio one way or the other. So this is an interesting slide looking at those 3 trials that I just discussed. And basically what it looks at is the expected rates of cardiovascular event rates in blue compared to the observed cardiovascular event rates. And what you see here is they're completely, they thought they were looking at high risk populations, but they really weren't. So Ascend was kind of intermediate risk patients, Arrive ended up being low risk patients, and Esprit was kind of more low risk patients. And that has a big implication when you think about risk benefit ratios. If you're prescribing medications for people that are really low risk, you're going to get more of the risks associated with it and the downside and not much benefit. And I think that's what happened with a lot of these trials. So this was the Arrive trial. This is another kind of methodological flaw with the trials. This is the intention to treat results of the Arrive trial. And that is the way you're supposed to examine clinical trials. So basically whatever they got randomized to, that's the way you would do the analysis. And it basically showed no real benefit from taking aspirin. The problem is there were only about 60% of people actually kept taking their aspirin for the trial. So they had a huge dropout rate. And if you looked at it, the per protocol results, meaning you examined people who actually took their aspirin compared to people who were given placebo, there was actually a significant risk reduction for people taking aspirin. Now, I'm not saying that this is the statistical way to examine the trials, but there are big methodological flaws when 40% of the people are not taking the prescribed medication. So it's really unclear what you're supposed to make of this. And this was true in the Esprit trial as well. They had a significant dropout rate as well. So there are some serious methodological flaws with this. The Arrive trial, like I said, had a very low adherence rate. They really looked at low to intermediate risk patients, not high risk. The Ascend trial, interestingly enough, was a positive trial. It kind of got in the press, it seemed to be, it was kind of, people thought that it was more negative, but it really wasn't. So the number needed to treat was 91. The number needed to harm was 112. So technically it was a positive trial. And then the Esprit trial, again, had a very significant adherence rate issue, and they were more low-risk patients. So this is a kind of busy slide, but this is basically a meta-analysis looking at all of these trials, so all of them. I think there are 13 of them all, and this is what they basically found, was that there was a modest reduction in risk of cardiovascular events, about 11%, and then there was an increase in major bleeding, about a 43% increased risk of major bleeding. And so the problem with this is, what do you do with this? You're kind of comparing apples to oranges, right? You're comparing a GI bleed to an MI. And I'm not sure how you make that in your mind. How do you determine, is it 1-to-1? Is it 1-to-2? But they clearly are not equal. And it's difficult for all of us, including patients, to figure out, well, do I want a GI bleed? Is that worth, or 2 MIs worth 1 GI bleed, or 2 GI bleeds worth, it's hard to kind of figure out. How do you wrap your brain around that? So that's one of the big problems with these trials, is how do you figure that out? And this brings up shared decision-making. And I'm not here to say I don't believe in shared decision-making. I think it's an important part of it. But it's really hard, because I can't tell how many times I sit there and spend 20 minutes talking to my patients about, this shared decision-making. And then they say, "Doc, what would you tell your mom to do?" And so really it all ends up back on us to kind of give them some information. I think shared decision-making is really important for a variety of reasons. But I'm going to try to give you guys some more information that you can find useful when the patient says, "Doc, what would you tell your mom to do?" So the latest aspirin trials had a lot of major methodological flaws and examined, in my mind, kind of the wrong patient population. They were examining low to intermediate risk primary care patients, which probably never needed to be on aspirin to begin with. So maybe we're asking the wrong question. Maybe it's not a question of should we use aspirin in primary prevention, but rather who are the high-risk patients in the primary prevention population that would benefit from aspirin therapy. So this is kind of a thought experiment. You're sitting in your office, and this patient comes in, maybe he's 40, 50 years old, maybe borderline hypertension, borderline lipids, no real strong family history. And you go through all the stuff you're supposed to do. You calculate his ASCVD risk, it's intermediate, low intermediate risk, and you say, go about your business. So he leaves our office, And 1 week later, he starts having chest pain. He comes in and he's got this tight LAD lesion. And it's the widowmaker, which is always interesting to me because whenever patients after their cath, they say, "Doc, did I have a widowmaker?" And when I tell them no, it's a right coronary lesion, like, oh, they kind of want to have the widowmaker because it sounds like a kind of a badge of honor, you know? So that's the widowmaker, proximal LAD lesion. So this is what he had. And then you sit back and you think about it. Well, when I saw him that week earlier, was he primary prevention or was he secondary prevention? I mean, technically he's primary prevention, but we all know he had a significant lesion right then and there. And so it really would be nice to kind of figure out what these people's risks are before their events occur. The problem is that the primary prevention population is very heterogeneous. You get your young people who are exercising, you get your couch potatoes, you get your vegans, gluten-free, get your Ironman marathon runners, your average Joe, and then you get this guy smoking, eating chips, and drinking beer. And the question is this is clearly not just one patient population. What we really want is to kind of separate these groups into various categories. And, you know, we do that, but we're not particularly, yeah, here's our buddy here with the party animal. And so we do that with our risk factors, but there's times when those don't really work all that well. So how do we identify high-risk patients in the primary care population that might benefit from aspirin therapy? So this is a case that I had. This is an actual case that came in my office. It must have been 6 months ago. So a 34-year-old woman comes into clinic with intermittent chest pain for the last week. She had gone to urgent care, obtained an ECG, and then they referred her to me because it was abnormal. Now, this was basically saying, well, yeah, go find a cardiologist and follow up with them in the next couple of days, which we'll see why that might be interesting. So she comes to see me 4 days later with this continued intermittent chest pain, no real past medical history, no family history. Blood pressure is, borderline, a little tachycardic, not overweight. LDL is good. HDL is a little bit low. Triglycerides are good. ApoB is fine and does not have diabetes. So this is the EKG. And this is her EKG. And she's sitting in my office. And so I keep looking at her. I look at the EKG. And I'm asking, are you having chest pain right now? She's like, yeah, I'm having chest pain right now. And, you can see these creepy looking T waves here. You can see some ST elevation here, some maybe Q waves. And I kept kind of thinking, like, what am I missing here? Because something is wrong. Well, this lady was having an ST elevation MI in my office, which brings up the question of, well, how do you activate the cath lab from your office, which is a little weird. And so we ended up having to send her down to the ER and got her into the cath lab, and she was cathed about 30 minutes later. And she had kind of a subtotal occluded LAD and a 90% RCA lesion and had it stented, and she's done really very well. The interesting thing is she had this LP(a) of 95, which is really high, which is a topic for a different time. But that was really the only risk factor along with a little bit low HDL. And this is a pretty dramatic case, but it raises the question of when risk calculators can lead you astray. And the problem is you have these young patients with a really high lifetime risk, but really low 10-year risk. They come into your office, they're in their 40s, you calculate your ASCVD risk, and it's always low. It's, it's usually like 1-2%, but their lifetime risk might be 50%. So what do you do with those people, right? Minority patients, especially a lot of Southern Asians, have a higher risk that really isn't included in our risk calculators. Patients with strong family history, and then patients with non-traditional risk factors aren't really included in our ASCVD risk calculators. So how can we improve on this? This brings me to my second case. So a 45-year-old woman comes in asking about aspirin therapy, no real past medical history, doesn't smoke, had this pretty significant family history. Blood pressure, again, is kind of borderline. LDL's high, HDL's, not great for a woman, and triglycerides are okay. So if you calculate the ASCVD risk, it's going to be low. I mean, it's a young woman. It's just going to be low unless they're, have multiple risk factors. So, this would say, well, she doesn't need anything. But the problem is you look at this and that makes you worried. At least it makes me worried. I don't like seeing that kind of family history. So I told her to go out and get a calcium score. So she goes out and gets a calcium score, and she's got a lot of calcium in there. And so this brings up the whole idea of calcium scoring, and maybe this can help us decide about who gets aspirin. But the reason I like calcium scoring is it takes all of these things and it funnels them into a calcium score and gives you a number. So it takes your good genetics we don't even know about. It takes your bad genetics we have, don't have any markers for. Exercise, smoking, diabetes, LP(PLA2), triglycerides, LP(a), HDL, LDL, diet, risk factors we don't even know about. And it funnels them into this calcium scoring. And at the end of the day, you get your score. And so it's an extremely useful test. some people are concerned about radiation, which is a legitimate concern. It's about as much as a mammogram, so it's not a whole lot. And you're not getting serial calcium scores, generally speaking. So it's really useful. And if you look at some of the numbers associated with calcium scoring, this is a very illustrative slide. If your calcium score, here's 0 down here. This next line here is 1 to 100. And then it goes up to, this is 100 to 300, and then above 300. And what really jumps out at you is this, the calcium score of 0. It's almost flat in terms of cardiovascular events. So it brings up this whole idea of the power of 0. And, we used to use calcium scoring to identify really high-risk patients, and it's true that it can, but it's really useful at identifying really low-risk patients that you can, as we say, de-escalate therapy. So potentially stopping statins, stopping aspirin, those kind of things. So the power of 0 is really important, and it's very helpful when we evaluate our patients. So this is just another slide looking at the increased risk. If you have a calcium score greater than 300, your odds ratio or your hazards ratio here is 9.67. That's a massive increase in risk. I mean, you talk about hypertension, you get like 1.4 is your risk ratio with that. Lipids, you get 1.6. I mean, this is a massive increase in your relative risk if you have a significantly elevated calcium score. This is just a slide that looked at, there's different ways we try to evaluate how much additive information does calcium score give you over traditional risk factors. And there's this whole idea of net reclassification index that we try to use to see if it's going to be an effective way to reclassify patients. What you really want is, you don't want people in this intermediate risk group, because that's this kind of group where you're like, what do I do? You kind of want people either they'll be low risk or high risk. So if you look at these kind of white bars here are without calcium scoring, and then these darker bars are with calcium scoring. And what you see is it reclassifies a lot of these intermediate risk patients either to low risk or to high risk. And at the end of the day, you get about a 23% net reclassification of patients, which might not sound like a lot, but it's pretty good when you look at other tests that are similar to it. And this was an interesting study where they basically took people and got calcium scores in the beginning and looked at whether they were on statin versus non-statin. And what you saw here is if your calcium score is 0, you really got no benefit from being on a statin. And then as your calcium score went up, you got more and more benefit. And so it suggests that it really is a useful tool at determining whether people need new therapies. So the similar thing was done looking at calcium scoring and aspirin. They basically took people and had calcium scores done on them. This was done in the MESA database, and basically followed them out to see if they had cardiovascular events, and then compared what calcium scoring would be like compared to the traditional risk factors. And so this is kind of a confusing slide. I'll try to walk you through it. So here on the left-hand side is number needed to treat, and here's calcium score 0, 1 to 99, and greater than 100. And so these blue bars are people that by the traditional ASCVD risk are less than 10% risk, and then if it's red, it's greater than 10%. So the bottom line here is that this is the number needed to harm by aspirin. So if you're above this line, then you're getting more harm and less good. If you're below this line, then, if you're below this line, you're getting more of the benefits and less of the harm. So what it's basically saying is that if your calcium score is above 100, it doesn't matter what your ASCVD risk is, you're going to get benefit from aspirin and not a whole lot of harm. And the people who have a calcium score of 0, they really don't need to be on aspirin. You're just subjecting them to the risks of aspirin, and they're not getting much benefit. And then the people in the middle, the 1 to 99, is kind of variable. It depends on what their ASCVD risk is. So I think this is a really useful study in the sense that I use a calcium score of 100 as my cutoff for who to put on aspirin. I mean, that's not for everybody, but in general, if your calcium score is above 100, I think they would benefit from aspirin. If it's 0, they absolutely should not be on aspirin. And if it's 1 to 99, it's kind of in between. So it's a really helpful number to kind of keep in mind. What about other predictors of ASCVD risk? So this is something that looked at carotid plaque. And it's interesting when you see a lot of these carotid studies that are done, a lot of times they'll just be read as, less than 50% or 50 to 69%, this kind of thing. And when I really try to get people when they read carotid studies to read them and tell us, do they have plaque or not? Because less than 50%, what does that mean? Does that mean 0 plaque? Or does that mean a 20% plaque? Or does it mean a 40%? I mean, that's a big difference. So what this study looked at is whether they had plaque versus stenosis versus normal. And what you can see here is normal had the lowest risk, thickening more risk, plaque, significant increased risk, and then stenosis, meaning I think this was greater than 50%, although I'm not completely sure, was even higher risk. The point is that if you have non-obstructive plaque, that's a significant increased risk for cardiovascular events, and it should not be ignored. So when you order a carotid study on somebody and you get a result back that says less than 50%, you should call up that person and say, do they have plaque or do they not have plaque? I'm not looking to operate. I'm looking at what is their cardiovascular risk. And I need to know if it was completely normal, which would be reassuring, or do they have plaque present? So this is a normal looking carotid ultrasound. You can see there's nothing ugly there. And this is the plaque that we notice. And you can imagine that, that whatever is happening in the carotid artery wall could easily be happening in the coronary artery wall as well. And this is just another study that looked at whether using carotid IMT and carotid plaque, not stenosis, but just plaque, whether that could reclassify risk. And they actually found that it reclassified similar amount to coronary calcium scoring. So I think there's a couple of different tests you could potentially use. Calcium scoring is really easy and standardized, and so that's typically what we go with. But carotid ultrasound can be helpful, I think. So what about mitigating the risk of bleeding from aspirin? So there have been a couple of studies that have looked at this. There were 2 randomized trials looking at aspirin use after having a peptic ulcer bleed. And they basically found that if you just re-challenge them with aspirin, there's about a 15% annual risk of re-bleeding. And Plavix was about an 8 or 9%. But if you gave aspirin and a proton pump inhibitor, that risk went down to about 1%. I mean, that's a massive reduction in risk by just giving them a PPI. And this was an interesting meta-analysis that was done that looked at whether proton pump inhibitor use had any effect on MACE. And the answer to that is no, it didn't. It was had no effect whatsoever. So I don't think this trial will ever be done, but I honestly think that if you did a trial in the future, you should have a combination of aspirin plus proton pump inhibitor versus placebo. Because my guess is that the GI bleeding rate would plummet. It's not going to change your intracranial hemorrhage risk, but it would decrease GI bleeding, which is the majority of the bleeding events that occur with aspirin. So that brings up intracranial hemorrhage. I mean, that's the one that we really worry about. I mean, GI bleeds are no fun, but typically people don't die from them. But intracranial hemorrhages can be really dramatic and catastrophic. So there's a large meta-analysis that just came out, I think like 6 months ago, and they basically looked at this risk. And there was an increased risk with aspirin. I think it was 1.37 was the relative risk ratio with it. What was interesting about it was that the only 2 things that seemed to matter with aspirin use that they could find was Asian descent, which seemed to have an increased risk of intracranial hemorrhage compared to patients that identified themselves as non-Asian, and BMI. So people that had a BMI greater than 25, it seemed to be protective from intracranial hemorrhage, whereas those that had a BMI of less than 25 had increased risk of intracranial hemorrhage. So I don't know what you do with this. I mean, it's extremely rare. So it's hard to, how do you do planning around this? I mean, I guess maybe if you had a really frail Asian patient, would you shy away a little bit from aspirin? Maybe. But those are the only things that kind of came out in this analysis. So conclusions, consider primary prevention aspirin in patients that have an ASCVD risk greater than 20%. I think we can all agree that the risks when you're low to intermediate probably don't weigh out the benefits. But if your ASCVD risk is greater than 20%, that's pretty high. And I think you can make an argument that those are patients that still would benefit from aspirin therapy. Calcium score above 100 are people that I continue aspirin therapy in. This is more of a stretch, but if you see a lot of non-obstructive carotid plaque in a patient, that might be something that would push me more towards prescribing aspirin. People that you shouldn't prescribe aspirin in, I think the Aspirin trial really found some significant bleeding with older patients greater than 70. And so in general, I'm not prescribing aspirin in those patients. Low to intermediate risk patients probably don't need aspirin either. And certainly patients with a calcium score of 0 do not need aspirin therapy as well. So this gets back to the kind of shared decision model. This is a paper that one of our own residents here, Anisha Thabani, Dr. Sperling, myself, and some cardiology fellows worked on, and it was accepted for publication. It sounds like it's coming out in December. But it's a nice kind of picture of how this works. So basically, you do your 10-year ASCVD risk assessor, And then you move on to the individual risk enhancing factors. I know you guys can't read this, but they include things like atrial brachial index, which I didn't really get into, coronary calcium scoring, elevated triglycerides, all these risk factors. And then you had to weigh that against the bleeding risks. So for your patients who have had bleeding risks in the past, or they're older, or they're very frail, and below 60 kilograms, maybe be worried about bleeding risk, have your discussion, and then come together and kind of figure out what exactly you're going to do. And I think importantly, you want to reassess and reevaluate risk periodically. I can tell you with calcium scoring, if it's high, like if you have a calcium score of 500, there's really no point in checking it again. But if it's 0, those people I do check it again, because they can calcify over time. And just because at 40 your calcium score is 0 doesn't mean that 45 it's still going to be 0. So I do check repeat calcium scoring in my younger patients who have a calcium score of 0. I'll check it probably every 5 years or so to see if it changes. And so I'll conclude with this: to prevent a heart attack, take 1 aspirin every day, take it out for a run, then take it to the gym, and then take it for a bike ride. And I think it's kind of true. I think our population has changed. I think people are in general kind of clued into all the cardiovascular risk factors that are out there, and they've changed a lot of their ways. And that's might be why aspirin's not as useful now as it used to be. I think it still has a role, but it's not, as Doug said back in the day, it really was kind of the mainstay of cardiovascular prevention. I think it has, to a certain extent, lost out to the statins. I think statins are safer, and they have a better benefit ratio as well. So with that, I'll take any questions that you guys have.
I guess one question I would have is what dose are you talking about?
Yeah, that's a good question. So in general, the data suggests that 81 has a slightly better bleeding or lower bleeding risk than 325. And while we haven't had a huge trial comparing direct 325 to 81, in general, the evidence suggests that 81 is better. I think there's a trial ongoing right now, I believe, it's looking at 81 versus 325, but I think it's in the secondary prevention patient population. But in general, I'm telling people 81 milligrams.
Question?
Question for one of the sites.
Okay.
Thank you. So I have a naive question. Do we know how aspirin prevents cardiovascular disease? Is it simply antiplatelet effects, or are there other mechanisms of prostaglandin inhibition or something that is mediating these effects over time? And can we, if it's something else, can we mimic it with a different drug?
Yeah, so that's a good question. I mean, I think the two things that generally speaking we talk about are the antiplatelet effects. But it does have an anti-inflammatory effect. It does lower CRP, and we know CRP is associated with cardiovascular events. So these are these things that are hard to figure out which part of it. It's like statins; they lower CRP. They will reduce triglycerides. They'll reduce LDL. But which one is the main part of it? It's hard to know.
Okay, we have a question from Midtown. How much does a coronary calcium score cost? And is it something that the healthcare system on a larger scale can support for primary prevention?
Yeah, that's a good question. So we do calcium scoring here for about $100. And in general, insurance doesn't cover it. It might occasionally, but it's $100. So it's, attainable for most patients. Some people have problems with that, but considering how expensive a nuclear stress test is, $10,000, this is a pretty good bargain.
Another question from Midtown. Is there any conversation between neurology and cardiology as to far as the risks and benefits for aspirin? Are the neurologists supportive of using aspirin too?
Yeah, I mean, I think that they certainly use it for people who've for stroke prevention. I don't know if they're using it so much in primary prevention of stroke. It's a good question. The results with aspirin have been a little bit variable on stroke prevention in the primary prevention population. Some have showed increased risk of stroke, and some have shown reduced risk in stroke. So it's a little bit unclear. But from my standpoint, I primarily am using it for prevention of coronary events.
I have found in my own experience recently with when the data comes out on aspirin, that neurology tends to be still using more aspirin than we in cardiology are at this time.
Yeah, I mean, they certainly use it for secondary prevention. I mean, that's the bedrock of their stroke prevention. Yeah, that's interesting because that was what the Physicians Health Study did. I mean, it was 325 every other day, which to me doesn't really make a lot of sense. But certainly we use statins every other day. But I don't know enough about the pharmacodynamics of aspirin to know, is that still effective or not? I mean, I guess it was in the Physicians Health Study, but I don't use it. Is there a reason? Do you do every other day? Yeah. Well, I mean, you have data to back you up. That's what the Physicians Health Study was. So,
A question from the VA. So it sounds like 0 calcium score, great. High calcium score, bad. How heterogeneous are the outcomes in those middle ground people from 1 to several hundred?
So let me just go back to this slide here. Sorry. So here's what we looked at. So here's 0 here, which is really phenomenal, and then the risk kind of goes up with, this is 1 to 100, this is 100 to 300, and this is greater than 300. So I mean, it's a somewhat linear kind of curve. The big thing that kind of jumps out at me is really the 0. The 0 is one that's striking here.
One other question from myself. So what percentage of your patients are getting 0 calcium scores? Is it a percentage or is it pretty low?
I don't have that number, but I'll tell you, it's kind of surprising. I think people who've ordered calcium scores will know. You'll have these people with, diabetes and their lipids are up, and you check a calcium score and you expect it to be really high and it's 0. So it's pretty shocking, I think, how many people have a calcium score of 0. And honestly, I've found the 0 almost more helpful than the high ones. That's just been my kind of anecdotal experience. And I will say that calcium scoring is really in the guidelines. A lot of the preventive guidelines have come out with it. The lipid guidelines have come out with it. It's really a big part of cardiology now, is calcium scoring. It used to be kind of this fringe movement, maybe 15 years ago. Now it's pretty much established, and it's very, very helpful.
Jefferson, we thank you very much. Appreciate it.
Thank you, guys.